Hello, everyone. We are about to get started with our webinar. We'll give folks just a couple minutes to join in on the call. Again, thank you all for joining us today. We're going to get started here in just a minute as folks join in on the webinar. All righty. Well, my name is Jessica Elliott. I'm a practice transformation advisor here at the Kentucky Regional Extension Center. Again, thank you so much for joining us today. We are here to talk with you about the hidden quality measures included in the quality category of the Quality Payment Program. We are going to be talking about administrative claims and performance and the impacts on your quality performance category. Now, before we get started, just a quick disclaimer. The information contained in this presentation is for general information purposes only and does not attempt to provide medical, mental health, or any other type of healthcare service. This presentation is not intended to be an alternative to medical treatment, and the content of this webinar may not apply directly to specific circumstances. The information is provided by UK Healthcare's Kentucky Regional Extension Center, and while we endeavor to keep the information up to date and correct, we make no representations or warranties of any kind, express or implied, about the completeness, accuracy, reliability, or suitability with respect to content. We will have a copy of our slides and the recording that will be made available to all of our clients within the next few days. We also, if you do have any questions during this webinar, please feel free to enter those questions into the Q&A box on your screen. All righty, and so today I am joined by my fellow advisors, Jared Deason and Vicki Harden, who will dive into the different administrative claims measures that pertain to this particular program. And now on our agenda today, we are going to be doing an overview of what are administrative claims, what does that look like, and how are they scored. We're going to go through and do a deep dive into each of the administrative claims measures that could potentially impact your overall quality performance category score. We'll also talk a little bit about MVPs and how administrative claims measures factor into the MIPS value pathway track of the program. And then finally, we'll talk a little bit about the scoring impacts and next steps on how to address those administrative claims measures. So with that, I will turn the presentation over to Jared Deason.
Thank you, Jessica, and good afternoon, everybody. So like Jess said, we're going to start discussing these hidden measures. And they're really considered hidden because they're often a second thought, once you go ahead and submit all your data to CMS at attestation, and they typically don't hit the majority of clinicians. For those participating in traditional MIPS, CMS evaluates and scores you on all administrative claims measures where you meet the criteria. If you're unfamiliar with these measures, it's likely that you just haven't triggered them before. CMS does automatically calculate these measures from the claims data you submit during the performance period. There's no additional data submission required on your end. And then later we'll kind of talk about how they impact MIPS value pathway performance as well. All four of these measures are risk adjusted and take in the complexity of each patient that falls into your numerator for these measures. So how do administrative claims measures affect your score? Administrative claim measures fall under the quality category and are added to your overall category score. This means you could be scored on more than just those 6 measures you're submitting during attestation. For individual clinicians, it's likely only one additional measure could be attributed, potentially shifting your quality score to a maximum of 70 points instead of 60. For groups, virtual groups, and APM entities, all 4 administrative claims measures could be attributed, making your quality score range from 60 to 100 points, with up to 10 measures evaluated. Even if you haven't seen these measures on your MIPS report, it's crucial to understand how they're calculated and triggered, especially if you are one of those providers managing relevant diseases or procedures. So let's quickly walk through an example here. In this case, the eligible clinician triggered one population health measure. They scored 30 points out of 60 for their 6 quality measures that they submitted. Since they were scored on an additional measure, the denominator increases by 10 points, making the total possible points 70. They didn't score too highly on this claims measure, earning only 2 points. So we would add those 2 points to the 30 points that they received, giving us a total of 32 over 70. Once you multiply that by your category weight, that would give them a category score of 13.71 points, contributing to their MIPS final score. So let's dive deeper into the first of our 4 measures today, hospital-wide 30-day all-cause unplanned readmissions. This measure evaluates the rate of unplanned readmissions to a short-stay acute care hospital within 30 days of discharge for any cause. CMS emphasizes this measure to help reduce avoidable readmissions and promote high-quality, efficient care. The denominator of this measure includes Medicare beneficiaries age 65 plus who have had an eligible index admission to a non-federal short stay acute care critical access hospital during the performance period. These patients must have been enrolled in Medicare Part A for the 12 months prior to the admission and the 30 days post-discharge. They must have been discharged alive and not transferred to another acute care facility. For your numerator, patients are included if they experience any unplanned readmission within 30 days of discharge. Planned readmissions do not count towards this measure, and only one readmission is counted if there are multiple that occur within that 30-day period. Same-day readmissions for the same condition as the index admission are excluded. If they were to come in with another condition, they could be counted. Index admissions are categorized into specialty cohorts based on their diagnosis and procedure codes used. This enables risk adjustment and the monitoring of standardized readmission ratios. Looking at how this measure is actually attributed to clinicians, it can be attributed to groups, virtual groups, and APM entities with a 200 case minimum. Readmissions may be attributed to up to 3 clinician group types to reflect the multiple healthcare roles do have an impact on readmission rates. The 3 clinician group types are primary inpatient care providers, outpatient primary care providers, and discharge clinician groups. If a patient has an index admission and is readmitted within 30 days, any clinician group that falls into one of these categories will have that readmission attributed to them. In the event that the clinician group played a part in 2 or all 3 of these roles of admission, the readmission would only be counted once for that group. Our next measure is unplanned hospital admission rates for patients with multiple chronic conditions. This measure evaluates unplanned hospital admission rates for Medicare patients with at least 2 chronic conditions listed in that box on the right here. CMS aims to highlight variations among MIPS clinicians and groups and admission rates with multiple chronic condition patients to incentivize better coordinated chronic disease management. For your denominator, the denominator will include Medicare beneficiaries age 65 plus who are at a high risk of admission due to 2 or more of those chronic conditions present within the measurement period before that admission. For your numerator, the measure counts acute unplanned admissions during the measurement period. Planned hospital admissions are again excluded in this measure as they reflect ongoing treatment plans and not so much the poor quality of care that may be happening. Exclusion criteria, admissions are not counted if they occur from a skilled nursing or acute rehab facility within a 10-day buffer period of discharge after the patient enters hospice care due to accidents or injuries, or with a primary discharge diagnosis of COVID-19. Patients that are attributed to hematologist or oncologist and hospice care at all during the measurement year, or those not continuously enrolled in Medicare Part A or B through the performance year, those will also be excluded as well. And for this measure, how it gets attributed, it uses a visit-based approach to attribute their patients to primary care providers or to specialists responsible for the coordination of care for those patients. Relevant specialists include cardiologists, pulmonologists, nephrologists, neurologists, and endocrinologists. Patients are assigned based on the number and pattern of the E and M visits being billed. They can remain unassigned, and I'll talk about that here in just a second. So for your specialist, they can be attributed to patient if they are identified as the dominant provider, meaning that they have had at least 2 visits with that patient, and they have 2 or more visits than any PCP or other specialist. So for example, if a patient visits a cardiologist 4 times, a primary care provider twice, and a nephrologist twice, that patient would be assigned to the cardiologist based on the plurality of those visits. For primary care providers, they will be attributed if there is no relevant specialist listed as dominant. And then they will also be attributed those patients to a primary care provider based on the primary care provider who has had the most number of visits. Patients may be left unassigned if they only saw a non-relevant specialist, they didn't see any primary care provider, or there are no dominant specialists identified. This measure applies to individuals, groups, subgroups, virtual groups, APM entities, and it only has a case minimum of 18. With that, I'm going to hand it over to Vicki, and she's going to walk us through the next 2 measures.
Good afternoon, everyone, and thank you, Jared. So we're going to continue talking about the other 2 measures. The next measure on your screen is complication rate following an elective primary total hip arthroplasty and a total or a total knee arthroplasty. The description for this measure is a complication rate for, of course, your Medicare beneficiaries age 65 or older who has experienced complications occurring from the date of the index admission to the 90 days post-discharge. The numerator for this specific administrative claims measure is a special if a specified complication occurs during the index admission and up to the 90 days post-date of the index admission for the elective procedure. Also, the measures use 3 years of inpatient claims to identify the index admissions for THA or TKA procedures, and 1 year prior of inpatient, outpatient, and physician Medicare administrative claims data to collect those diagnoses for risk adjustment, and 90 days post-index admissions for outcome determination. The specified complications are listed on the right side of the slide. We'll just go through those briefly. Acute myocardial infarction, pneumonia, or sepsis shock, surgical site bleeding or pulmonary embolism, death, or mechanical complication of periprosthetic joint wound infection. Your denominator is, of course, patients enrolled in Medicare fee-for-service, ages 65 years or older, who underwent any inpatient elective primary THA or TKA. Now, THA and TKA procedures are qualifying procedures without the following. And if you refer to the right side of the slide again, you will see that these are not qualifying procedures if there's been a femur, hip, or pelvic fracture, partial hip arthroplasty, revision procedures with a concurrent THA, TKA, resurfacing procedures with concurrent THA or TKA, a mechanical complication, malignant neoplasms, and removal of implanted devices and prosthesis. Okay, now talking about attribution for this specific claims measure, the measure attributes complications to either the MIPS participating clinician or the clinician groups. There's a requirement of 25 cases for this measure. They look at the 3-year performance period when looking at the data. They access both Part A and B Medicare administrative claims data to collect diagnoses for risk adjustment and 90 days post-index submission for outcome determination. And this measure can be attributed to individuals, groups, virtual groups, or APM entities. Okay, so let's break down the attribution. So for only one clinician bills for the THA or TKA procedure. The algorithm that the CMS uses an algorithm that identifies and assigns the individual as the billing surgeon. Patients may have different claims for the same procedure, so that the algorithm is what assigns the attribution to that billing surgeon. If 2 or more clinicians bill for THA or TKA procedures, the algorithm will seek to identify the clinician who billed for a THA or TKA procedure and is not an assistant at surgery. If a single clinician who is not an assistant at surgery could not be identified for assignment, then the algorithm identifies whether there is a single clinician who was an orthopedic surgeon and assigns this as the billing surgeon. So if the algorithm cannot identify a billing surgeon using these 3 rules, then they will identify whether an operator is listed on the institutional claim. And if not, the patient is not assigned to a clinician or clinician group, so therefore they're excluded from the measure. So that's kind of how this attribution is broke up for this measure. The next administrative claim measure is acute cardiovascular related hospital admission rates for patients with heart failure. So these are unplanned cardiovascular related acute hospital admissions. That's your measure description. For the numerator, the outcome for this measure is the number of acute unplanned cardiovascular related admissions per 100 person years at risk for admission during that measurement period. And of course, the denominator, you have to be enrolled in the Medicare fee-for-service, age 65 years or older, and then have a discharge diagnosis of heart failure or cardiomyopathy. There are some excluded admissions, and the measure does not include these admissions, and these are planned cardiovascular related hospital admissions, admissions that occur directly from a skilled nursing facility or acute rehabilitation facility, admissions that occur with a 10-day buffer period after a discharge from a hospital or a skilled nursing facility or acute rehabilitation facility, admissions that occur after the patient has entered hospice, admissions before first visit to provider if no visit in year prior to measurement period, admissions following left ventricular assist device implantation, start of home entropic therapy, or heart transplant. Heart transplant, that's a mouthful. So the attribution for this measure, the measure attributes admissions to MIPS clinician groups and assesses each clinician's group admission rate. And as updated this year, September the 5th of 2024, they updated this measure to only attribute to these groups, these subgroups, virtual groups, and APM entities. That these groups have to have at least one cardiology and have to have at least 21 case minimums to be attributed. There is a 1-year performance, a period that CMS will calculate from inpatient claims. The measure is calculated from inpatient claims, outpatient claims, beneficiary enrollment data, medical equipment claims, American Community Survey, and area health resource files. And breaking down the attribution for the clinicians. So first, if an assigned cardiologist is considered dominant, if they have 2 or more visits with the patient, and that's how a cardiologist is considered dominant, 2 or more visits with the patient, regardless how many visits the patient has with the PCP, then that cardiologist is going to be attributed. If a patient has seen a primary care provider at least once but has no visits with the cardiologist, then that PCP will be attributed. If a patient has only 1 visit with the cardiologist but has seen the primary care provider at least twice, then that PCP also will be attributed that measure. At the practice level or at the 10 level, patients are first assigned to the clinician most responsible for the care. Patients that cannot be assigned if they only saw non-relevant specialists and if they have not seen a PCP. They will not be included in your attribution. All right, so moving on to MVPs and administrative claim measures. How do they relate? So population health measures are a foundational layer, and they are also calculated through administrative claims. Out of the 4 administrative claim measures that we just talked about, 2 are available as population health measures. And why is this important? It's important when you are registering for your MVP or your MIPS value pathway. You are required to choose at least 4 measures that you can report on and a population health measure. That is a requirement at time of registration. You will not be scored on that population health measure if you do not meet the case minimum or if you do not have a benchmark. So you may choose a population health measure, but it may end up that you don't even score on the measure. Population health measures and cost measures will be evaluated at the affiliated group score. And I know we've said this a couple of times, but no submission is required for population health measures. CMS calculates the score based off of claims. All right. So an MVP scoring example, just to give you an idea how population health measures can affect your scoring. So we have an example of heart health. Heart health registered to report the advancing care for heart disease MVP at the group level. They reported 4 ECQMs that they felt that they were doing pretty well in, and they selected the risk standardized hospital admission rates for patient with multiple chronic conditions population health measure. So they earned 30 points for the quality category out of a possible 50 points. And you multiply that by 30%, which is the category weight, they received 18 points out of a possible 30 points for their quality MIPS score. Now, to break that down a little bit more, so they received 28 points for the 4 ECQMs that they chose upon registration. They only received 2 points for the multiple chronic condition population health measure, which gave them a total of 30 points earned. For their denominator, they received 10 points each for each ECQM, which give them 40 points. But they also, it also was worth, the population health measure is also worth 10 possible points. So that was a total of 50 points. And you multiply that by 30% category weight, and you get 18 out of 30 possible points. So you did see a difference in the denominator on this scoring example. All right, so let's look at traditional MIPS scoring impacts. So we have 2 scenarios. We have one who the practice ABC Health did not trigger any administrative claims, so they were scored solely on their ECQMs. Then you have scenario 2 where administrative claims was triggered. So I want to show you kind of the differences in scoring. So for ABC Health, they submitted 6 ECQMs. They earned 50 out of 60 points, which was pretty good. You multiply that by 30%, which again is the quality category weight, and their final score for quality was 25 out of 30 possible points. So you go down to scenario 2, where administrative claims were triggered. They earned 50 out of 60 raw quality points based on their ECQMs, and they met the threshold for hospital-wide readmissions and multiple chronic conditions. Each administrative claims measure earned 2 out of 10 raw points. So you have 50 points for your ECQMs. You have 2 points for hospital-wide readmission and 2 points for multiple chronic conditions, for a total of 54 points earned. For your denominator, you had 60 possible points for your 6 CQMs, 10 points for your hospital-wide readmission, and 10 points for your multiple chronic conditions, which gives you a total of 80 points possible in the denominator. Multiply that by 30% quality category weight, and you get 20.25 out of 30 possible quality points. So there is a 4.75 difference from the score, solely based by having administrative claims triggered for your submission. So that's a pretty big difference. So it's important to look at these administrative claims. And with that being said, I'll move on to best practices for identifying opportunities for improvement. So the first thing you want to do, if you've never been scored on an forgot to advance my slide, sorry. First thing you want to do is, if you've never been scored on administrative claim measure, you want to review those 4 administrative claim measures to see what could possibly be scored for you in the future or for this current year. Then once you do, and once you have identified those measures, you definitely want to you want to kind of do a deep dive into those measure specifications. You want to look at your case minimums, your reporting period, the denominator, numerator criteria, and any exclusions that may or may not pertain to that measure. But if you've previously been scored on administrative claim measures and you have patient level data, then you can review that data and start identifying some data trends and review the measure performance. And also look at your historical measure performance to establish, where you were, where you would like to be, and identify those data trends that could possibly move you up the scale for improvement. All right, I'm going to hand it back.
Sorry, Vicki. Thank you so much. Thank you, Jared. Thank you, Vicki. I appreciate you all going in detail around those measures. They can definitely be tricky to navigate and have some serious impacts on your final MIPS score. So definitely something to always keep in the back of your mind if you are going to be, looking at potentially meeting those case minimums around those measures and how much they can truly impact your bottom line. So we'll give folks just a minute or two. If you do happen to have any questions, please go ahead and put those into the Q&A. And then while you are doing that, we are going to look at some of our upcoming webinars and educational material, actually through the rest of the year. I can't believe we're already here talking about November and December. We actually, next month in November on the 12th, we are going to be having the Year in Review Roundtable. This is going to be pre-recorded, open to the public webinar. So we will get that emailed out to everyone, and it'll also be released on our website. We will also be at the same time releasing our QPP 2024 attestation prep overview. It's a mini video, and this is going to be client only. And it's just a walkthrough of getting yourself, your organization, your data together in preparation. Again, hard to believe we're already talking about it, but in preparation for submission for performance year 2024. That window will open up in January and will extend through March of 25. And then finally, in December, our last webinar of the year, we are going to be taking a look at the physician fee schedule, the final rule to go into effect for 2025. And so it's going to be a highlight of that entire rule. We're going to make sure that we bring out any of those need-to-know details that are going to impact any of the tracks of the quality payment program. So be on the lookout for that. That's on December 17th. We will be sending out calendar holds for those live webinars so that you can log in and attend in person. We will also send out recordings of that if you're unavailable as well. And then wanted one last announcement. If you haven't heard or haven't received one of our emails, we are hosting the Innovating for Better Health Outcomes annual conference. Each and every year we host an annual conference at the REC, and every year I feel like our agenda keeps growing and the content is more enriched. So please feel free, if you haven't already signed up, we would love you to attend. We have an in-person option and we also have virtual option as well. You can scan that QR code. We will also make sure that we have a link to the registration sent out in our reminder emails and with a copy of the slides. But we have some fantastic speakers who will be sharing their expertise with you. Our keynote speaker is Harold Dennis Jr., and he is a fantastic, captivating speaker who's really going to be talking to us about destiny and choice. He is actually a survivor of one of the worst drunk driving accidents in U.S. history that happened here in the state. It was the Carrollton bus crash, and he has a very captivating, unique take on destiny and choice. So we're definitely looking forward to hearing from him. So again, you can join us virtually or in person for this. It's going to be held Thursday, October 24th. So hard to believe, just next week at the Campbell House here in Lexington. Let's see. I don't see any questions in our chat. But if you do think of something, want more information, your advisors are here to be able to send out any of the measure specification sheets around the administrative claims. And then just in our monthly advisor calls, we'll be more than happy to help answer any of the questions you have around the content of this webinar or any of our webinars. So again, want to thank you for your time, and thank you to Jared and Vicki for walking through those measures for us. And I hope everybody has a lovely rest of your day. Thank you.